Introduce today. Last person to introduce today is Kathy, and she's going to be talking about pain and pain treatments out there for seniors and everyone else. I'm going to turn it over to Kathy. It's all you. Kathy, you're muted.
Thank you. Good morning, everyone, and thank you for joining us. As Dr. Baldwin stated, my name is Kathy Friday, and I am one of the learners this month with Dr. Baldwin. And today, I will present on a very complex topic of pain and treatments for pain. So this quote states, pain is whatever the experiencing person says it is, existing whenever and wherever the person says it does. So this is why it is helpful to understand some of the symptoms felt and why they may be different. After this presentation, we all should be able to describe the pain pathway and what affects it, develop an awareness of misconceptions and consequences of untreated pain, differentiate between threshold and tolerance, recognize different types of pain and identify appropriate analgesics for each type, identify the differences in pain medications and what they are used for, utilize pain assessment tools as needed for residents or clients, explain that all team members have a role in assessment and treatment of pain. And lastly, identify opioid overdose, addiction, withdrawal, and where to get help. The reason why pain is taken very serious in the US is because its prevalence is high and it affects everyone. The CDC, Center for Disease Control, compared chronic pain and high impact pain in the US and compared it among different populations. High impact chronic pain was defined as persistent pain with substantial restriction of life activities lasting 6 months or more. As you can see in the graph placed, both chronic pain and high impact pain are higher among those 65 years and older. Other populations that have a high prevalence for chronic pain are women and non-Hispanic white adults. High impact chronic pain was also highest among women when compared with men. The other bar graphs to show those that I just stated are shown in the handout for your reference. So according to the International Association of Study of Pain, pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Everyone experiences pain differently. Some may cry, be irritable, feel angry. Some sit depressed without expressing it to anyone. Older patients think this is just part of aging, but it's not, and tend to not report their pain. Self-report of pain is the single most reliable indicator of pain. Institutionalized elderly often can endure pain without showing their feelings or complaining. Pain is common at end of life as a result of arthritis, circulatory disorders, immobility, neuropathy, cancer, and other age-related conditions. This is why the purpose of pain is used as a warning signal to the brain. It aids in fight and flight response and causes protection from harmful stimulus. Everyone involved in the care share in the role of pain management. Everyone must know how to recognize and report pain. But before we get into that, I just wanted to make the distinguish between threshold and tolerance, because a lot of times we can get this mixed up. One person's report of severe pain may seem like almost nothing compared to another. Our challenge is to assess all relevant factors without imposing personal biases. Threshold is defined as the point at which a stimulus, usually one associated with pressure or temperature, activates pain receptors, and produces a sensation of pain. This varies among everyone. For example, I may be able to stick my finger in water that is about 60 degrees Celsius without feeling pain, but another person will remove their finger from the water when it reaches 45 degrees Celsius because they start to feel that sensation of pain. Tolerance, simply put, is how much you can take and deal with. There is this misconception that males or elderly people tend to have higher tolerance, but some studies have shown there to be more factors other than age or sex. Factors that can negatively affect pain threshold and tolerance to pain are things like lack of sleep, stress, age, and experience. So I wanted to go through a little bit of the pathophysiology. So the three main structures involved are the peripheral nerves. These are specialized cells that carry information for things like mechanical, thermal, electrical stimuli, the spinal cord, and brain. Tissue injury leads to the release of inflammatory mediators with subsequent nociceptor stimulation. Pain impulses are then transmitted to the dorsal horn of the spinal cord, where they make contact with second-order neurons that cross to the opposite side of the cord and ascend via the spinothalamic tract to the reticular activated system and thalamus. The localization and meaning of pain occur at the level of the cortex, but also sent to our memory and emotion centers in the brain. There is also a neuromodulation, which is how much pain is actually felt involved. Major trauma can cause desensitization. For example, someone being in a major accident may not feel the pain on impact, or a soldier in the warfield does not feel pain because they are more focused on staying alive. And sometimes non-painful impact, like someone with diabetic neuropathy, can feel painful when the feet is touched by a blanket. The brain can amplify the signal, turn it down, or even tell nerves how much of a signal to send up in the first place. Nerve sensitivity can be set by the brain and or conditions right in the tissue. Even the structure of the nerves can and do change. Gate control theory, or GCT as I will call it, was proposed for the first time in 1965 by Ronald Melzack and Patrick Wall. Gate control theory of pain is a mechanism in the spinal cord in which pain signals can be sent up to the brain to be processed to either make more noticeable or prominent perceived pain, or attenuate, meaning reduce it at the spinal cord itself. It has been studied that touch and pain travels through the same gate. So if a touch and pain stimulation happens at the same time, as you can see in the first figure on the left, through the alpha beta AB fiber, that's where the touch is stimulated through, and the C fiber for the pain. It will close off the gate of pain, which will be felt. You will only feel the touch. This also brings in the reason why massage therapy is used to treat pain. Acupuncture is also an example of that gate theory and is also used to treat pain. In your handout, you will see examples of conditions that can open the gate and conditions that can close the gate. And one that we're going to be talking about further in this presentation is medications. Medications can close that gate. Now on to classification of pain. Pain is frequently classed as acute or chronic. Acute pain normally lasts less than 3 months, is short, may be sudden or slow. Some examples are broken bones, strep throat, and pain after surgery. While chronic pain lasts greater than 3 months. Some literature says greater than 6 months per se. They persist beyond the healing period and can be difficult to find a cause. Examples of chronic pain are arthritis, cancer pain, and fibromyalgia. In chronic pain after tissue injury, pain signal is turned on, but not turned off. And the chemical response is not turned off after injury is healed. So more and more sensitization at periphery, meaning more specialized cells activated, nerve cells, and more signals sent to the brain. Your mood may become low, and this impacts the quality of life. Lastly, acute pain can also be felt during chronic pain. Another classification is by physiology. Two types are physiological or pathological. The first type is biologically useful, adaptive, and protective. Examples of that is nociceptive pain and inflammatory pain. Pathological have no biological function and is due to damage and or abnormal function of the nervous system, and examples are neuropathic and CNS dysfunctional pain. I just want to mention pain can be further classed by specific type. For example, cancer pain. This pain is often the first symptom causing patients to seek treatment, but patients may be reluctant to report increasing pain because of fear that an increased pain means a worsening of their disease. That is why a lot of research is dedicated to pain management. The two main types of pain seen, as I illustrated here, is the nociceptive and neuropathic pain. Nociceptive can be somatic or visceral. Based on what type of pain it is, can be felt very differently, have different duration, and be at a different location. Neuropathic pain are sensory abnormalities that causes varying degrees of pain, sensations from numbness to hypersensitivity to a tingling, burning, sticking, or prickling type of pain. The effects of untreated pain is dynamic. Here is an image showing how pain in general affects our bodily system. As you can see, effects of untreated pain, they have effects on the cardiovascular system, CNS, respiratory, the GI system, endocrine system, and they also have some psychological factors. Here is a table outlining what changes are seen in body systems. For example, untreated patient can lead to increased heart rate and blood pressure, increased respiratory rate, increased susceptibility to infection, increase your blood glucose, blood sugar, which can make it difficult for those who have diabetes, reduce gastric emptying and intestinal motility, and that could cause constipation, nausea, vomiting, urge to urinate, or urinary incontinence, meaning that you may not be able to make it on time to the bathroom, tense muscles local to injury, and you'll see shaking or shivering, changes in pain processing, increased risk of pain becoming chronic, and cause anxiety, fear, depression, and poor concentration. Risk factors for pain are both modifiable, can be changed, or non-modifiable. The modifiable risk factors are pain, mental health, other comorbidities, smoking, alcohol, obesity, lack of physical activity or exercise, sleep, nutrition, employment status, and occupational factors. The non-modifiable risk factors are age, sex, cultural background, socioeconomic background, history of trauma, injury, interpersonal violence, and genetic factors. Pain does not have to come from a physical injury, but pain do have genetic components to it as well. Questions about your pain covers what your pain feels like. So with the diagnosis, they're going to go through questions to really understand how that pain is. and how they can treat that pain. So whether or not it's a burning, stabbing, aching, pinching, or throbbing pain, how bad it is and when it started, its pattern or duration, what it is associated with, and how it is affecting your daily life. Question about health history covers any diseases, injuries, or disabilities you have had or diseases that have occurred in your family, and whether you drink alcohol or smoke. Questions about what you have done to treat the pain addresses what works or does not work based on your past experiences. Also, they will need a complete list of your medications, like prescription medications, over-the-counter supplements, or herbal remedies. They may need to do a physical exam, lab, or imaging to see if there's another condition associated with that pain. This is an example of a mnemonic, well, it's called Socrates, that is used in the clinical settings of what questions they may ask you. So the S is for sight, O is onset, C, character, R, radiation, A, association, T, time course, E, exacerbating or relieving factors, and S, severity. Asking about pain is an important part of all assessments. Everyone, again, caring for the residents, need to know how to report pain. Charge nurses must assess all reports of pain whenever someone is in the hospital. And that may be daily checks or sometimes hourly checks, depending on how bad the pain is. Assessments to identify or treat pain must be ongoing, and elderly residents require frequent monitoring for pain. Pain, this is a pain scale that is used. Pain can be ranked from 0 to 10, 0 being no pain, and 10 worst pain you can imagine or complete interference with all activities. Mild pain ranges from 1 to 4, moderate pain ranges from 5 to 6, and severe pain ranges 7 to 10. Here are the different pain scales that are used. There's the visual analog scale, the numerical rating scale, which is B. The second one, I'm looking at the black and white image. C, the third one is the verbal rating scale or verbal descriptor scale. And D, which are the two at the bottom with the faces, are the faces pain rating scale. PEG, or pain intensity and interference score, is the pain intensity and interference score is a tool used often to assess chronic pain. When setting goals for chronic pain, the goal is never to treat to bring pain level to 0, but to bring a reduction in that pain felt. The P stands for pain intensity, E, enjoyment of life, G, general activity. And these are all scaled from a 0 to 10 as well. Other considerations when assessing pain, firstly, we need to be careful not to stereotype. Elderly may be less expressive with pain, and this can be due to cognitive decline and inability to express pain. And this can result in increased combativeness or agitation rather than typical pain symptoms. A full and detailed assessment is needed. Bolded there, you see culture do affect how pain is interpreted and addressed on a personal, family, and community level. The barriers are inability to speak English, may result in undertreated pain, punishment for wrongs, because some culture think pain is some sort of punishment for a wrong, natural pain management, divine healing powers, again, that could be with culture, and stoic versus expressive, meaning someone who could take the pain versus someone who is very expressive with pain. Patients with cognitive impairments or communication issues, like patients with dementia, traumatic brain injury, Alzheimer's, and even those who are not able to communicate, maybe due to a language barrier, They also need to be assessed properly and may not be able to use those scales that we looked at before. In these patients, you want to be alert for behaviors that may indicate pain, like facial expressions, physical movements, compliance with if they're on a mechanical ventilation, vocalization, bodily movement, and muscle tension. Proxy pain reporting by caregiver, family, and clinicians are also used. So those people can also report the pain if the patient is not able to. Pathological conditions that may, be a barrier. Again, we say like Alzheimer's, dementia, things like that. And physiological, which is like heart rate, blood pressure, respiratory rate. And those will be, you will see those elevated in someone who has pain. Now to pain treatment. First, I would like to touch on the non-pharmacologic treatment, meaning no drugs used in these. There are physical techniques that can be used, like massage, positioning, hot on cold, acupuncture, TENS, progressive muscle relaxation, and exercise. Psychological techniques are cognitive behavioral therapy, mindfulness-based stress reduction, acceptance and commitment therapy, biofeedback or guided therapy. And other techniques listed there are spirituality, religion, and music therapy. Some of these you may need a referral from your doctor to get, but some of these therapies you could get on your own. You could assess that on your own. Now moving on to the pharmacologic treatment. The World Health Organization analgesic ladder was a strategy that was proposed in 1986 to provide adequate pain relief for cancer patients. This analgesic path, developed following the recommendations of experts, has undergone several modifications over the years and is currently applied for managing cancer pain, but also acute and chronic non-cancer painful conditions. This is due to a broader spectrum of diseases such as degenerative disorders, musculoskeletal diseases, neuropathic pain disorders, and other types of chronic pain. So as you can see there, the first step, like we're gonna do it as if we're stepping up. So the first step is for mild pain, and you want to use non-opioids or an adjuvant. And we're going to look at what those adjuvant medications are. When you get to mild to moderate chronic pain, and say, for instance, the non-opioid pain is not working, all the therapies down there isn't working, then you want to introduce an opioid. And we'll get into what those opioids are, or continue with another non-opioid or adjuvant. And then for moderate to severe pain, you want to get to, again, if all of those don't work, then you want to continue with maybe another opioid that is much stronger. And as you can see there, they have morphine and fentanyl in that example. So here are some non-opioid analgesics, over the counter or OTC that you could get. So the first drug class is acetaminophen. You may hear it called as Tylenol, see it written as APAP, APAP, paracetamol. In my country, we call it paracetamol in Trinidad, or Panadol. The use is for mild to moderate pain, may be used as an add-on for severe pain. It has some antipyretic effects, which means it can lower fever, and is first-line agent for osteoarthritis. Some considerations is that the max daily dose in geriatric patients is 2 grams, and the max dose for those who take in warfarin is 2 grams as well. Tylenol or acetaminophen can cause some liver impairment. It is metabolized in the liver, meaning the drug needs to be cleared through the liver, and that could cause some issues if someone has a liver impairment. So you really want to be careful if you have any issues with your liver taking this medication. Overall, Tylenol is well tolerated, and you should avoid use with alcohol. The other drug class is the systemic NSAID. Those are non-steroidal anti-inflammatory drugs. The one we see a lot is aspirin. You have ibuprofen, naproxen, or celecoxib, which is also known as Celebrex. These are anti-inflammatory. They are primary analgesic for nociceptive pain, and contraindicated mean that they should not be used in patients undergoing a coronary artery bypass surgery and with end-stage liver disease. This medication does give a high risk for renal toxicity and GI toxicity. The adverse effects is that it can cause heartburn, GI ulceration, and GI bleeds, which is why while if someone is taking warfarin or clopidogrel, this can also increase their bleeding risk. To reduce some of those GI toxicity, patients are often recommended to combine them with like a proton pump inhibitor like Prilosec or famotidine. Topical NSAID is one that I've heard a lot is diclofenac. I've heard a lot of people say that it works really well. It works for localized pain. So if you have pain on your knee or any pain in that area, you can rub it there. It doesn't have systemic absorption, so it doesn't have that big side effect as NSAID does. But there are some side effects that can be seen. When you put this on, you want to make sure you let it dry before going near any open flames. And you want to do that with any topical agent that you're using for pain. One that is not mentioned there is the lidocaine 4% patch. You can also get that over the counter. So here are the non-opioid analgesics, RX, meaning these you need a prescription in order to get them. And I'm not going to go in detail with all of these, but I'll just touch on some antidepressants are used, like fluoxetine, duloxetine, anticonvulsants like gabapentin, pregabalin, antispasmodics like cyclobenzaprine, methocarbamol, corticosteroids like dexamethasone, and again, other non-NSAID topical analgesics like the lidocaine, the 5%, and the patch and the capsaicin cream. A lot of considerations you want to take with these. I have included a more detailed chart in the handout for your reference as well. Now we're going to get into the opioid drugs. The ongoing opioid crisis lies at the intersection of two substantial public health challenges: reducing the burden of suffering from pain and containing the rising toll of the harms that can result from the use of opioid medications. And this was a quote taken from the Pain Management and the Opioid Epidemic article that was written by the National Academies of Sciences, Engineering, and Medicine. So this is not inclusive of all the opioids, but this is a little chart I placed here in your handout. You will see much more about them. One is tramadol, also called Conzip or Ultram. This could be used for fibromyalgia. And again, opioids, you more or less want to use them for, in the clinical settings, they will use them for like moderate to severe pain. Chronic back pain, neuropathic pain, or osteoarthritis. There are some considerations to be taken with tramadol, as these can lower seizure threshold, and you want to caution in patients with renal or hepatic impairment. And meds are tapered off to avoid withdrawal, and this is for all opioid medications, and I will go into that a little further. Short-acting opioids or long-acting opioids, these are used, again, for moderate to severe acute or chronic low back pain, osteoarthritis, neuropathic pain, and they also use to treat pain after surgery. Whenever you taking an opioid, you may be normally prescribed a bowel regimen, and again, meds need to be tapered off to avoid withdrawal. Some adverse effects you can see from these are sedation, cognitive impairment, respiratory depression, constipation, nausea, and vomiting. An overdose can lead to coma or death, which is why you want to make sure that you're taking this medication the way your doctor prescribed. And we will go into those a little more. Opioid overdose. Opioid overdose is serious because it can lead to coma and possibly death. Opioid overdose is a life-threatening and requires immediate emergency attention. And I put this here because recognizing signs of opioid overdose is essential to saving lives. And I think we all should know this. So you want to call 911 immediately if a person exhibits any of the following symptoms. Their face is extremely pale or feels clammy to touch. Their body goes limp. Their fingernails or lips have a purple or blue color. They start vomiting or making gurgling noises. They cannot be awakened or unable to sleep, and their breathing or heartbeat slows or stop. Now, these symptoms can be seen for other diseases. So you want to assess to make sure that person is taking an opioid, currently on an opioid. But if it looks alarming and this is not something that the person you would normally see in that person, then you definitely want to call 911. Opioid use disorder is a medical condition defined by not being able to abstain from using opioids and behaviors centered around opioid use that interfere with daily life. Being physically dependent on an opioid can occur when someone has an opioid use disorder, and that can be characterized by withdrawal symptoms such as cravings and sweating. However, people can misuse opioids and not have physical dependence. When a person has physical dependence, it can be particularly hard to stop taking opioids. And that dependence can interfere with daily routines, including personal relationships or finances. Opioid addiction has a serious impact not only on the person who has a substance use disorder, but also on their friends, family, colleagues, and others. And in that image is a list of signs and symptoms seen in opioid addiction. Here are the symptoms seen in opioid withdrawal. Again, opioids are tapered off to avoid withdrawal. Even if your pain has gotten better, you may be given a dose reduction for a week or month, depending on the drug, and dose to gradually and safely get you off the medication. So you might be wondering, why am I still on this medication? I no longer in pain. But opioids need to be gradually reduced so that you do not get withdrawal. Some symptoms experienced during opioid withdrawal is shown in the figure, along with when it may be seen. So for example, if someone abruptly discontinued their opioid treatment, 72 hours after, they will start experiencing chills, fever, body aches, diarrhea, insomnia, muscle pain, nausea, and dilated pupils. A week after, they'll start experiencing tiredness, sweating, body aches, anxiety, irritability, and nausea. 2 weeks after, depression, anxiety, irritability, restlessness, and trouble sleeping. And after a month or so, symptoms can linger for weeks or months. They'll have that craving and depression still. There are places in North Carolina to get help for someone in opioid overdose, withdrawal, or addiction. A list of drugs used for these are shown in the figure, like methadone, naltrexone, buprenorphine with naloxone, lofexidine, and naloxone. State health director authorizes any pharmacist practicing in the state of North Carolina and licensed by the North Carolina Board of Pharmacy to dispense naloxone to any person who meets certain criteria. And those criteria are in the handout as well. Again, if you suspect someone is experiencing an opioid overdose, immediately consider the following actions to save their life. Call 911. If the person has stopped breathing or if breathing is very weak, begin CPR, best performed by someone who has that training. and if available, treat the person with naloxone to reverse opioid overdose. In the handout is also listed ways that patients or family can access naloxone when in an opioid crisis. There are also clinics and recovery programs established throughout North Carolina to help someone who has opioid use disorder. The NC STOP Act was signed in by Governor Cooper due to the increasing rise in opioid misuse and abuse in North Carolina. The STOP Act stands for Strengthened Opioid Misuse Prevention Act. This puts prescription limits on Schedule 2 and 3 opioids for acute and post-operative pain. So for instance, for acute pain, someone could only get 5-day supply, and for post-operative pain, they can only get a 7-day supply. Additional pain medications may be authorized after, depending on the need of the patient. Prescribing limits do not apply to medications administered in hospitals, nursing homes, hospice facilities, and residential care facilities. So with all the problems with opioids, there are some advances to create more non-opioid medications, and these are 2 listed here. The BNOCPA, or also known as the benzyl oxycyclopentyl adenosine, is an adenosine A1 receptor selective agonist. The indication for this is chronic pain. It is found to be a potent non-opioid and powerful analgesic, but do not cause sedation, bradycardia, hypertension, or respiratory depression, which is really good news. The VX548 is a selective sodium V1.8 inhibitor. The indications are for acute and neuropathic pain. The Food and Drug Administration has granted breakthrough therapy designation for this drug for the treatment of moderate to severe acute pain. Clinical trials for both of these drugs are still currently going. Lastly, we never want to leave out lifestyle modifications. And in Rebecca's presentation earlier, she had detailed perfectly what you want to do in terms of your diet, exercise, and sleep. Other things you want to do with pain is you want to be careful about footwear. You want to make sure you're not wearing something that is too tight. And that could also go for clothing. Stop smoking, keep your weight under control. You want to drink enough water, maintain your vitamin D and calcium levels. You want to maintain an upright posture while eating and sitting. You don't want to slouch because that could elevate that pain. You also want to wear good fitting clothes and sleep on the side or the back, but do not sleep on the stomach as it puts a lot of pressure on your spine. So take-home points for this presentation. Pain is best treated with a combination of pharmacologic and non-pharmacologic strategies. Pain is a complex response requiring proper assessment and management. Pain is more than a sensory experience having affective, cognitive, sociocultural, and spiritual dimensions. Pain management can be optimized when each patient is thoroughly assessed, reassessed, and engaged in the treatment planning. So these are my references, and thank you all for listening. What questions do you have?
All right, who has questions for her? Does anyone have questions for her? You might be lucky and no one might have questions for you. I'm not seeing, Kathy, any questions in chat or anybody unmuting themselves, nor have I seen any come through. Ooh, wait. Nope, that's just a great presentation. So I'm going to go ahead and